I don't know if many of you have come down to Fort Belvoir or come up to Fort Belvoir. This is a beautiful facility. The old Walter Reed on Georgia Avenue closed down August of 2011. The new hospital is a $1.4 billion hospital, which includes numerous additional buildings. So this hospital, this is the hospital part, and it's a 140-bed hospital with private rooms. So they have the ability to double up if they need to. The reality is the war is winding down, and so we're taking care of other things. There's 900,000 retirees and dependents in the CapMed area, the Washington, D.C. area. So we have 3 cardiac cath labs, 2 linear accelerators for breast cancer and cancer therapy. It's really set up as a community hospital. The Bethesda Hospital has got several buildings to it. That's it's called the Walter Reed National Military Medical Center. The old term was the National Naval Medical Center. But this is the largest hospital ever built at one time by the federal government. The 4th floor, which you can only see 765, the next one below that on the north side is the inpatient psych unit, and on the south side is the addiction medicine unit. And then in addition to that, you have 2 large clinics. You're seeing half of one clinic here. There's another clinic over here, 2 clinics on that side, and each of those are 3 stories tall, and they're seeing about 1,000 to 1,200 visits a day at the hospital right now. So it's revved up and it's gotten busy. The capacity, though, is about 2,500 visits a day. So it's only at half capacity. So things are moving very rapidly to get that done. But if you stop by, you want to visit, you want to see our program, just give me a call. You can go through the people here at Farley. But the thing is that we're very proud of what we're doing. Now, what's interesting, we've had 189 admissions. We've had about 160 discharges. We had 5 people who were dismissed because they were not participating in the program, or they get into altercations on a unit or things like that. We've had 6 people go back to psych because of suicidal events. Of the 160 people who've been discharged over the course of 14 months, now some people have been out for 14 months, some people have been out for 1 month. We've only had 19 relapses of those 160. So we keep tabs on them, and these are observed urines too. So it's not like you send a card to them and it says, I'm fine, everything's going well. Now, we're going to talk about TBI, brief talk, but explosions are a mechanism of injury. And there's 3 things that happen whenever there's an explosion. The first thing that happens is that you see this big boom, and things are flying all over the place. But something has already happened that you haven't seen. And what's happened is there is a spherical event that occurs. Now, when I say spherical, think of it in 3 dimensions. And you can actually see it right here coming out. That event is coming at you at about 600 miles an hour. It's almost the speed of sound. So it's flying out, and the 11 Bravos, which are infantry, and the Marines tell us that when they're running into a battle and there's an explosion, they see this visual thing fly right through them. And then the second part is the debris field. So what happens is things are boom, 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 and the shock wave hits them and things like that. And then there's an implosion, because when things go out, they got to come back in. So if they can adjust to the pressure going against them, all of a sudden they're pushed forward and they land on their gut. And so there's 3 things, and it all happens in a very quick, like 1 to 2 second basis. But that first wave, this right here, has always been a question. We have not seen this happen in the US with only rare exceptions. And one of those exceptions is there, whoops, I don't have the picture here. I thought I had the picture there. One of the exceptions was in Boston at the Boston Marathon. Now remember the old man who was running towards the end. Now this guy had been in over 26 marathons before, and he's running along, the explosion occurs, and he just kind of folds down. Now, it wasn't because the pressure knocked him over, but that pressure wave that went out, that spherical event that came out, and it's almost imperceptible, has a change in the way that people perceive things, and he just sort of crumpled. Now, the debris field, the shrapnel that was going out and everything else, caused injuries, amputations, things like that. That's the second wave, and then there was a small explosion. As bad as it was a small explosion. And then, so the implosion was not that great. Now, when you explode something really big and it blows up, And then if you have military-grade explosives are different than dynamite, for instance. And so those explosions are much more rapid. It's called a power issue. Power is mass times speed. And so you have more power in some of these military-type materials. Now, this is what happens to essentially the old Humvee. And this right here is the new Humvee, which has an inch of armor everywhere around it. So you're thinking that if you're inside this, you must be safe because the bottom is a V. So if it blows up underneath you, it doesn't blow the vehicle 50 feet in the air, it only blows it 20 feet in the air. But you don't have any airbags in that. And so when you hit something going 40 miles an hour, like a wall, your head still crashes against the windshield. Even though you're wearing all your gear, you still have a change in the way the brain is experiencing the event. So you can have a loss of consciousness, or you can have an alteration of consciousness. So LOC or AOC. If you have an alteration of consciousness that lasts for a day, by definition, you have a moderate TBI. Now, what would an alteration in consciousness be? You can't remember the name of the guy who's in the bunk next to you. You can't remember where the DFAC, the dining facility, is. And I've had many men who would get lost back inside the wire. They couldn't figure out where stuff was. You can't remember the name of your commanding officer. Now, these are alterations in consciousness. You can't remember all three of your kids. You can remember two, but not three. So these are alterations in consciousness, and these are very significant findings. So the term that people use are, he's what? He's goofy, right? And the spouse says, well, there's something wrong with him. What is it? I don't know. It's just, he's different. And so they come back here and they say they're different. Well, that creates a problem because we don't have a good term for goofy, right? It's not in DSM-5. And so we need to do more evaluations. But the entire diagnosis is based on what the person remembers. How long they're unconscious. I can't remember.
Does an LOC or an AOC qualify as a concussion in any way?
All concussions are TBIs. Now this is interesting because we have a recognition. Any of you who have teenagers in high school right now realize that you have to go watch a movie and then you have to talk about spinal cord injuries and concussions and traumatic brain injury. The NFL has a big issue going on right now with over 1,000 prior athletes suing the NFL for TBI when the NFL knew it was going on and they still said, get in there and knock them out and I'll give you a bonus if you can knock somebody out. I mean, that's how crazy we've gotten in this system. Now, the other thing that's interesting, I have a patient on my unit right now who is in that turret up there, and this thing is going 65 miles an hour, and they hit a big bump in the road, and the guy turns real hard, and the thing rolls over twice. Cracks his helmet, cracks several of the plates of his body armor, and of course, it's like, well, you got to be taken care of, but you know, the response is, I'm staying here. I'm fine. I'm with my men. I'm staying with my battle buddy. I'm not leaving. And so he ends up doing that. So do we have a diagnosis of a TBI there? No, we don't have it. But then when I bring him back here, he had the event in May 2012. I get an MRI on him, and he has a bleed the size of my thumb in his brain that was undiagnosed. So he's going to TBI now. So you have these events that have significant impact in regard to the trajectory that the service member is going to have. And is that any different than a kid who's out goofing around and they're playing rock toss and he gets hit in the head with a 3-inch rock? But he doesn't want to tell mom. So he wears his hat all the time because he's got a big egg on the side of his head. You see how these types of events can be very similar. Now, the explosive events in my mind are very different. Hopefully this is not going to become routine in this country. But the thing is that, you know, even though everyone thinks we're winding down the war, there's a lot of people in this world that still don't like us. And so there's opportunities to cause trouble. So we have different definitions for what TBIs are. And the World Health Organization, the Centers for Disease Control, everybody is trying to get what's called reduced variability. You've heard that term a lot, to get it down to what is this really? But we don't have a dipstick test. The MRIs are not good screening tests. But something's coming down the road that's interesting. I think I may be at the end of this battery. Okay, so now, if you think of nerves, So an MRI doesn't give us the granularity necessary to see what's going on. But if you get down to the microscopic level, all of a sudden it makes sense. So the nerve that makes my toe work is a nerve that's right here. It starts in my low back, and actually it gets higher. It starts at about L1, and it goes all the way down to the tip of my toe. Thanks. And that nerve is like a big, long tube. So if you take this nerve here and we extend it out all the way to the parking lot, it's still got a long ways to go because this is a microscopic nerve. And inside the nerve, we have all these little tubules, and there's fast tubules and slow tubules, and we have an insulation around the nerve called the neural lemma. And the neural lemma allows rapid stimulation. So when you step on a tack, you pull your foot back real quick. It's not like you have to have these chemical reactions go all the way up there. So you have fairly rapid transport of information, and the reason you pull your foot up is the information goes from your toe up to right here, it goes into your spinal cord, it goes all the way up to your head. Your head says, hey, danger, danger, we're stepping on something that hurts. And then all of a sudden it goes back down and you pull back. Now, when we have that, remember that shock wave? Now we can't get this unless we have a piece of your brain. As it turns out, people don't like to volunteer that. And so it's not easy to get this information, but when people die who have TBIs, we can go in and take necropsies of their brain, and we see this information. And this is what bothers us, is that, what is that? Now, if you have a brand new headphones, and you saved up $200 to buy one of those new fancy headphones, but you didn't get Bluetooth, you got the plug-in kind. And then you go into the living room, and you see your 6-year-old child waving that thing around like it's a slingshot. And you scream, don't touch that! And you take it back, and you plug it in, and you hear and you're thinking, what's going on? Well, the reality is you have a short, right? A short in the system. And that's what this is right here. Now, if everything you thought came flying out of your mouth, how well is that going to work for you? So you're sitting in Bank of America. It's Friday afternoon, really. You're in Bank of America, and you're waiting to be taken care of, and you realize you only have 45 minutes. The boss gave you an extra 15 minutes to go down to the bank, and you got this check you want to cash, and you're waiting in line, and there's a patient up there saying, isn't it so nice here today? I mean, it's not as hot as 2 weeks ago, but it's just warm enough that you could go out and you could have your bikini on, and you could lay in the sun and get a little tan. And you're looking like, come on, lady. But you say it. He says, what's wrong with you? Why are you taking so long? Now the security guards are starting to look at you. And you're doing this kind of thing, back and forth from one foot to the other, and come on! You see what's happening? Now let's take this another situation that happens with TBI, and I think almost every wife thinks this, like every husband has this problem, but you say, we need a dozen eggs. They go to the grocery store, they get $92 worth of stuff, 6 bags of groceries, and when they get back, they're really proud that they saved $16 at Safeway. Okay, it says right on the tag. And then you say, where are the eggs? And we say, what eggs? Now, this is a chronic problem for TBI. Thank you. A chronic problem for TBI. So what happens is that now things that you, and then after your spouse tells you, what's wrong with you? I sent you down for a dozen eggs. And then what you're thinking flies out of your mouth. So not a good thing, right? So we have impulsivity, we have difficulty with short-term memory, and what's interesting is that when we look at this process, well, I'm going to stop off with this right here. So there's a guy named Jim Kelly who's in charge of our NICO, the National Intrepid Center of Excellence, and he is truly one of the best neurologists in the country. He was at University of Colorado for many years, and I knew him back at Northwestern back in the 1980s. And his specialty is concussion syndrome. Military grabs him and brings him to NICO. He actually goes to Kandahar and he develops the process of what's called the MACE eval. The MACE evaluation is this process of evaluating anyone who has a concussion. And so they say, they run over, they talk to the person, they say, do you know what month it is? Do you know what day it is? Do you know what day of the week it is, what year it is, and what time it is? That's basic alert to, time, place, person. Then they say, I'm going to give you 5 words, and I want you to repeat those. Elbow, apple, carpet, saddle, bubble. Elbow, apple, carpet, saddle, bubble. I'm going to ask you those questions, and I'm going to ask you some questions, then we're going to come back and ask those 5 words. Now, that actually is short-term memory. And so he asks us, we get the system set up, and then we have them give us a few more, I want you to repeat to me backwards this 3-digit number, 493, you say 394. Now, we get all done with that, I'm going to say, okay, what were those 5 words? Okay, so now if you have good short-term memory, you should remember at least 3 of them. The problem was when Jim went over to Kandahar, and he's sitting down with the 11 Bravos and the Marines, it turns out that they had a little laminated card with this on the side of their helmet. Now, why would people do that? Because if they were exposed to an explosion, as it turns out, military who are involved in combat are exposed to multiple explosions on every day of their mission. If we use the term of 30 meters, if you're exposed to something within 30 meters, I've got men who say, and women, who say hundreds of times. I mean, we don't even count them. But if I can't remember these 5 words, they're going to pull me offline. And I'm an important person. I have a job to do. And if I'm not there, that job doesn't get done. I am not going to leave my unit. You see our problem? So when we say we have a certain number of TBIs, I actually believe that we have an underestimate. Now, some of the symptoms go away quickly. So the headache you get after an explosion, this is when you're in the field, this is when you're in post-deployment, this is when you come back. So people who have headaches after the explosion, they get better. People who have dizziness after the explosion, they get better. But look at this. If you're irritable, it doesn't get better. If you have memory loss, it doesn't get better. Now we got a problem, right? Because if someone says, I can't remember where the DFAC is. Now there's only so many tenths. If you can't remember where the DFAC is, you got a massive injury from the standpoint of function. If someone has to be assigned, hey, take Decker to DFAC 3 times a day, there's something wrong with that. You see what I'm saying? So the goal here is that we need to identify these patients at the front end, and we need to pursue. But the thing is that if we identify them, then they get pulled off the unit. They get pulled off the unit, and something happens. That patient, that service member has survivor guilt because I was the person who's supposed to have the 50 cal, and something happened. I should have been there. So you can see how people stay in the system. So that, and then a second injury, and a third. And when I talk to people who say, how many times are you exposed to explosions? They say, well, which 2 are you talking about? Well, the last one you're on. Are you talking about in a day or in the whole time I was there? I was there for 14 months. It had to be hundreds. Hundreds. And these are people who don't have penetrating wounds. So just the exposure to all those events has an effect. Now, this is our NICO facility, the National Intrepid Center of Excellence. It's at Walter Reed, just south of the emergency room. We opened up the NICO at Fort Belvoir on July 22nd, just this week. It was opened up. Now, this is one of the interesting things that we have. Now, how many people have ever climbed a tree in their life? Okay, so when you're young, you're 7 or 8 years old, the tree represents something. It represents accomplishment. So what happens is you're climbing the tree, and you get up to the first branch. You don't stop there and jump down. You go to the second, the third, fourth. Ultimately, you run out of tree, right? But you're on your way up there. You're 30 or 40 feet above the ground. And you see things that you never saw before. I mean, the other side of the tree, and you get to see distantly. There's a hill way over there. I can see so-and-so's house from up here. And you're way up there, and you think, I can go a little higher. And there's something that happens that tells you you've gone far enough. And that's usually a crack, okay? Now, when a tree limb cracks, it always cracks at the same place. It doesn't crack way out here. It cracks at the junction, at the crotch. And this is what's interesting. If we look at the corpus callosum up there, and you see that branch that goes into the occipital branch, we've blown that up over here. These little lines you see are not individual nerves. These are large bundles of 50 to 200 nerves. They're called brain tracts. And there's a new software, if you have a 3 Tesla unit, it's called brain tracking software. There's about 100 units in the country right now. Walter Reed had one of the first units. But you notice right there, we got a problem. Because those bundles, and it's not one nerve, it's dozens of nerves that are broken at that point. Now, if you have Jell-O, and I like Jell-O that has the mixed fruit in it. So my wife will make the Jell-O, and she'll put the mixed fruit and mix it up. and then it gets hard. And then there's a piece of cellophane or handy wrap over it, and it usually says, don't touch. So now, if we get it out, and if I shake it, the Jell-O doesn't break, in random places. It always breaks where the fruit's at. Whenever there's a change in the density, that's where the break occurs. So when you take and you shake the head up, now if you ever seen a necropsy or autopsy, the brain is hard because it's hardened up already. But if you look at a live brain after an injury, I was a paramedic for 4 years before I got into med school, and you have people with open head injuries, it's just like Jell-O. I mean, it's just like white Jell-O and blood, and sometimes people have massive injuries and it's all on the floor. And so what happens is that this right here doesn't give them a lot of structure, whereas the nerve bundles are hard. And where you have nerve that's hard and you have brain that's soft and you shake the head real hard, you start to shatter things. And then when you have a crotch in the hard surface, it breaks at the crotch. Now, what's an issue here is that we are now able to see things that we couldn't see 10 years ago. And so with the new brain tracking software, we're able to have a better idea what's happening with traumatic brain injury. Now these are still, this is still macroscopic. In other words, it's still looking at the things that are big enough to see. We don't have a system that's able to see microscopic, which is really where the brain injury is at. But we're getting better. So I believe that the evaluation of TBI is going to change over the course of time relatively quickly. Now, when we start adding PTSD to it, and I'm going to assume this crowd knows what PTSD is. We add PTSD to it, you see that we have an overlap that's significant. So we have childhood traumas, and we have combat traumas. I have a soldier on my unit right now that did the cleanup when those 39 men were killed when the helicopter was blown up, with the SEAL Team 6 on it. When it came down, there was significant, everybody died in that helicopter, but he was one of the people that was assigned to pick up the pieces and put them in containers to have them sent off for DNA analysis. He still can't stop thinking about that. Now, if you drink enough, the dreams go away. But if you don't drink, the dreams come back. So he's suffering from flashbacks. He's suffering from nightmares. He also has banged himself in 3 car accidents in the past 3 years, civilian car accidents, while he's on furlough. Why? Because he's drinking. And when you drink and you drive, bad things happen. But he can't sleep. He's very irritable. He has high levels of anxiety. The doctors put him on benzodiazepines. As it turns out, benzodiazepines don't help PTSD. Then he also is starting to feel depressed because, as his wife says, he's different. Now these are not combat-related TBIs, but every time you shake the brain hard enough, things change. And so he's different because of the PTSD, but he has a TBI, and these two things together create a different disorder. Then when you add substance abuse on it, because substance abuse seems to make the nightmares less remembered. I think they're still probably having nightmares, but they just don't remember when your blood alcohol is 300. And it also makes this normal. Remember we talked about headaches usually go away, dizziness usually goes away, but irritability and impulsivity, they don't seem to go away. So what happens is that we've got patients who have these types of problems. Now, every one of our patients, with rare exception, are going to become your patients. That's understood, right? The military, at some point in time, they leave the military. Sometimes they end up with you. Sometimes they end up in treatment. Sometimes they do very well. Only 60% of active duty military ever visit a VA. Only 60% ever even visit a VA during the course of their life. This is looking at World War II, Korean War, Vietnam War, and Gulf War I. So that means that 40% never even go to a VA. That means that they are only taken care of by the civilian community. We need you to be able to do the evaluations. So when we mix PTSD and TBI and we add on substance abuse, and this Venn diagram, you start to see as you're going deeper and deeper into this, it's not just one problem. So when you have a program that says, well, we're a PTSD program, we just deal with that. It's sort of like when you go to your dermatologist and you say, oh, by the way, can I get my blood pressure medicine too? They say no. So in behavioral health, though, we can't do that. We can't tease out and say, well, I just take care of your childhood trauma, and your combat trauma really needs to be taken care of by someone else. What's the message we're giving them? Your problem's not important enough for me to address. And so we have to have something different to say. We have to have something that makes more sense to the patient. That doesn't mean we can do everything, because remember, Dr. Decker's a bad therapist. Okay? I'm going to just tell you to change the locks and get a lawyer. But the thing that's an issue is that we have to have something that says to the patient, you're important. You're important for us to do everything possible to help you. And that we have, working together, the ability to address these needs. It doesn't have to be just at one site, but you do have to have a network of people you're working with. And you want to be able to activate that process when needed. So we have PTSD issues, we have pain issues, we have substance use disorders. When we have sensory system problems. I've got a guy who got air evac'd out of Afghanistan just 21 days ago, and his glasses got left in Afghanistan. So and it turns out, when we asked him to do the daily reading, he can't read. Now, he can't read because he can't see. It's not because he can't read. So I said, well, all you got to do is ask. We'll give you the glasses. He says, well, my glasses are Afghan. I said, they actually make them here? So we can do this? So, and it's just like, well, I didn't want to ask for things that, I'm here to get taken care of because of my drinking problem. I said, no, actually, you're here to get better. And to get better, that means we need to look at the big picture, which includes their TBIs, which includes their musculoskeletal problems, which includes their chronic pain issues, which includes their marital problem with their spouse, which includes, go down the list of all these things that it includes. DSM-5, when we start looking at the changes, addiction medicine got turned on its side, so we have to redo everything at this point in time. But there's other things. So if you had Asperger's, all of a sudden you don't have it. Well, what do I have then? So there's some things that we have to sort of accommodate in dealing with DSM-5. When we start looking at other symptoms, you can see the list right here. There's lots and lots of things that could be associated with PTSD. But the reality is many of our patients and many of your patients address PTSD with self-medication. So I don't know what it is, but Vicodin makes me feel better. Well, I'm going to tell you something. Vicodin is not going to make you feel better. What it does make me feel better, I said, no, Vicodin numbs you. And you're looking at numbing as feeling better because you're not feeling the things you need to feel. I said, we have treatments that actually can address PTSD. And there are intervention strategies that do have a better trajectory than not treating the patient at all. So if we look at evidence, then we start going down that path. Let's look at what works. So we have distraction techniques. Rapid eye movement's a distractive technique. Tapping people who just tap their leg on the floor all the time, they're distracting themselves, and that's dealing with their anxiety. But the reality is the distraction techniques work. So if you get to a point where you're revving up, let's use a technique that's going to help you. You can, and what's nice about rapid eyes, you don't really have to pay a lot of money for it. And the same thing goes with tapping. So Walter Reed, they had a tapping. You tap yourself 10 times on one side, 10 times the other side, 10 times the front, your chin, find 6 places, do 10 times each. Hey, I feel better. Now, is that curing the problem? No, it's just distracting it. I think we need to go to the next level. What is it about PTSD that causes it to have such a chronic stranglehold on some patients? And what can be done to help that patient? I'm not looking for a pill. I'm looking for something else to help healing occur. I actually think with TBI that some of the techniques that are going on right now in regard to medication, such as vitamin therapy, may have and reducing free radicals, because when you injure things, all kinds of stuff happens. And it's actually kind of exciting what's happening right now, that we actually may be using some medications in the field to decrease the effect of TBI. Because when the brain's injured, the assumption was when you injure the central nervous system, you're screwed. Well, that turns out not to be true. It turns out that why do kids, when they lose half their brain, I'm talking from trauma or from tumor, they end up doing pretty good. But adults, we can't make that happen. Stem cells make a difference there. You see what's happening? So I do believe that we're going to have better answers down the road. We're just not there yet. Social consequences. When we start looking at, when you have a person where everything they think flies out of their mouth, they have poor impulse control, can't remember things real well, they have a short fuse, what's that going to do to a relationship? What's that going to do to intimacy? You can see how quickly that's going to go belly up. And I'm dealing with our highest risk patients for substance use, the 18 to 29-year-old males, and those patients become your patients, and they're still 18 to 29-year-old males. And so we have that culture, that genre, that syndrome that we have in our country that, on a Friday night, you're going to get lucky, you're going to get into a fight, and you're going to get drunk, and that's as good as it gets. That's a pretty sad thing that we have going on, but that's the mentality that a lot of people have, and we have to deal with that. When we start looking at exposure to combat and what that does to them, we start to see a whole variety of things happening. Combat will bring back traumas from your childhood that you don't even remember. And there's something about the relationship between adverse childhood events and combat trauma that seem to go hand in hand. And so when we start looking at it, and then we know very clearly that adverse childhood events and substance abuse go hand in hand. So we need to start considering this as part of our diagnostic and therapeutic intervention. If we don't deal with it, it doesn't seem to get better. PTSD is one of those things that if we do whack-a-mole, in other words, every time it's a problem, just knock it down. I'll tell you what, we're going to give you a little Seroquel, that'll take care of the problem over here. That one is going to be an effexor one there. If we keep doing that, it always pops up again. It's not going to get better with just medication. So we have to have other techniques that make sense. Military families have a load of issues. I mean, what's interesting to me is that 60% of the military have kids. And we very seldom don't look at the kids as an asset. We only see the kids as a stressor. If there's a way to provide intervention, parent-child interactive therapy, all of a sudden the family unit becomes a protective unit rather than a stress unit. And the sad thing is, when there's stress in the family, most times it results in relationship dissolution. And that's not the answer either. And it's not the answer for this kid. If you think we paid a lot of money for this war, you haven't paid the next generation yet. This war is an expensive war for a lot of reasons. It's not just because of equipment and burial costs. It's because of what's going to happen to the family down the road. If we don't take care of the 3- and 4-year-old today, you're going to be paying a lot of money for that 17- and 18-year-old down the road. And so the thing is, we have to look ahead and see that, not use just myopic vision. We've got to have a little bit better distance vision in this too. We start looking at mental health problems post-deployment. Suicidal ideation is still very small. But there are 347 men and women active duty service members that committed suicide in 2012. I do the LODs for every suicide at Fort Belvoir. They're very inconsistent except for one thing, impulsivity. So it's not like people who have come in for help, obviously they're asking for help, get them the help they need. But we don't have a good way to measure the ones that are not asking for help that are in danger. And we've got to get a better way to do this. And there's not a lot of evidence that what we're doing right now works. So we use the ACE cards, we have the suicide hotlines. There's not good data that supports that those are beneficial for the ones who are actually going to commit suicide. Now there's a lot of people who ask for help that way, which is good, but they're probably not the ones that are at risk. So it's a real challenge for us as to how we handle that. So we look at Operation Enduring Freedom, which is Afghanistan, Operation Iraqi Freedom, which is Iraq, we start to see a lot of things that have to happen. We need to screen more people for PTSD, and it's looking at about 1 out of 6 to 1 out of 10 are going to have PTSD who are combat exposed. And that's, I think, a conservative number. And we put that together and we realize that alcohol use rates in this population are unacceptably high. 42% of those 18 to 29-year-old males drink to the point of intoxication every week. Now, when you look at the entire population, officers and else, then you're starting to look at smaller numbers. Anywhere from 1 to 6 to 1 to 10 have alcohol use disorder. But that's not a whole lot different than the general population, and I don't believe it. I believe the numbers are higher than that. It's just that if you ask for help, it's command interest, and then all kinds of things happen. So the response is, it's like the kid that's in high school on the sports team. You smoke marijuana, you have those little memory jogger. You smoke marijuana? Of course not. Well, let me ask you different. You smoke the killer weed? No, I don't do that either. So what happens is, if people know there's going to be significant consequence, they back off and help. There is a thing called the KTEP, which is Confidential Army Substance Abuse Services, and KTEP at Fort Carson has been significantly beneficial for people to be able to ask for help. If you have an active duty service member, there is one place they can go to for confidential help that has been very positive, and that is the chaplaincy. So we have 2 chaplains who are addiction certified therapists at Fort Belvoir, and so if we have someone who says, I can't tell you. Now when someone says I can't tell you, sometimes it's security they can't tell us, and sometimes I don't want to tell you I can't tell you. So my thing is, if you want to talk to an officer, let's get you with Father Mercado, let's get you with Major D, and they will be able to work with you confidentially. So I'm going to stop now because I've gone over my time. So we'll take any questions on TBI, PTSD, and substance abuse, or if you have any pain questions. Go ahead. And we have a pass-around microphone, too. Questions? Is this helpful? Okay. Yes?
11%, 11.8% active duty, and 15% reserve. The active duty is because of not reporting.
Well, I think the numbers are down. The numbers are down across the board because in the military, you are property of the U.S. government. Now, and I'm not trying to say that demeans the active duty service member, but an active duty service member that admits I have an alcohol problem becomes a command interest. And the command has to provide intervention services. That creates a discord. Because if you're saying, listen, I've got 4 years in, I like my job, I want to stay here, I see myself as important, I support the mission, I'm loyal, I'm patriotic, but I got drunk at my brother's wedding and I can't quite remember everything that happened, should I tell you about it? It's never happened before. That's a reportable event. Now, does that, if the person doesn't say anything, it's not reportable. But that person has a problem. And we know that if we intervene in that patient, we can actually help the patient not have that event again. But if we don't intervene, unfortunately, it could happen with a driving event or something else. And so this is Dr. Decker's personal opinion as a civilian in the military, but I'm not representing the military. I do believe that it would be helpful for active duty service members to be able to ask for help. And to be able to do so. Now, I don't believe that, by the way, if they have cocaine. I don't believe that if they're shooting up heroin. I mean, if they say, I got a problem, I'm shooting heroin, we got to know about that. Systems got to know. Yes? KTEP, and it's at Fort Carson. It's a confidential intervention service that's run by Army Substance Abuse Program, ASAP. And it's experimental right now at Fort Carson in Colorado. Yes?
So if they use that, I guess what I'm confused is, their superiors are going to know eventually if they're in treatment or not.
No, treatment is different. So KTEP is a KTEP is an evaluation. If the person has a significant alcohol use disorder, in other words, they need to go into Army Substance Use Program, then it's command interest. But a person can come in and just, right now what they do is I have a friend, and they do it that way. But, and that happens in civilian world all the time, right? But the thing is that we need to have a system that allows service members to get help at the front end. Prevention should not be just primary prevention. There should also be secondary prevention. And so that's something that's being worked on. The Institute of Medicine, and if you look up IOM, they have a December 2012 publication. It's called Substance Abuse in the Military. It's an excellent, matter of fact, I think you're going to get, let me just show you for a second. You're going to get this when you get on the website here. I gave them, I gave them this issue here. So you'll be able to get this from the website, and this has been released information. So what happens is that we talk about all the services that the Institute of Medicine did, and so they actually, the DoD asked the Institute of Medicine, you know, the Institute of Medicine is assigned by Congress to evaluate different things that are going on. So they were asked to evaluate substance abuse in the military. And it's a star-studded blue panel that did this. So they came to Fort Belvoir, Camp Pendleton, Fort Hood, Lejeune, and so they went to different sites to identify what would be the next step for the military to address substance abuse issues. And they did a very thorough job in doing that. And so this is on the website. So you'll post this one too, and you can get that. Okay? Thank you very much. Yes?
Can you elaborate just a bit on you talked about the combat injuries provoking childhood memories?
Yeah, so,
how that works in terms of brain activity?
well, so the question is, what is it about combat trauma that makes childhood trauma surface again? Now, we have a thing called repression. So something happened to us when we were 7 years old, and we have not told anyone. And then you have a traumatic event. The person who you went through basic with, who you marched for the last 9 months through, gets a bullet through his neck, splits his spinal cord, and you're holding him while he dies. And no matter what you do, you cannot save him. And then this person comes back to you in your dreams and keeps on saying, help me, help me. but you can't do anything. And then what happens is when something happened to you, you were 7, and that same emotion comes back and percolates up. So I think it's a psychological event. Now, I'm not a believer in repressed memories, but I am a believer that PTSD is something that we repress, and then what happens is that when it erodes through, it creates all kinds of issues. And so now in therapy, you can't just deal with the combat trauma, you have to also deal with the trauma that occurred earlier in life. And military sexual trauma, not even a topic we touched today, huge issue in regard to PTSD, and many of these women and men, because it's not just a woman issue, have had traumas in their child or adolescent years that percolates up when you have combat trauma in the adult years. Okay? That's another topic we have to come back for. It's a huge issue. Thank you very much.